We'll be breaking down all major concepts covered on the exam.
Right, getting you completely ready for test day.
Exactly. But first, imagine you're laughing so hard at a joke that you suddenly lose all muscle tone and just collapse to the floor. Fully conscious, but, entirely paralyzed.
Sounds terrifying.
Right. Well, welcome to this deep dive into section S08 Neurology, focusing today on sleep disorders. We are your MCCQE reviewers, and before we begin, a quick note.
Yeah, the mandatory disclaimer.
You know it. This deep dive is for medical education purposes only and does not constitute medical advice. Any clinical decision should involve a qualified healthcare provider.
Absolutely. So our mission today is to help you, the Canadian medical student, feel completely comfortable with the exam review process. We're going to tackle the highest yield information from reliable StatPearls articles.
And we've got a really interesting thematic setup today, don't we?
We do. We are basically looking at two opposite sides of the sleep disruption coin.
The two sides of the coin.
Exactly. On one side, we have narcolepsy, which is all about the pathological intrusion of sleep and REM into wakefulness.
Right. Sleep forcing its way in.
Yeah. And then on the other side, we have restless leg syndrome, or RLS. That involves a physical urge that actively prevents the onset of restful sleep.
Okay, so let's start with that intrusion side, narcolepsy. The scenario I just mentioned where you collapse from laughing, that's cataplexy.
Right, which is the hallmark of type 1 narcolepsy.
But the core symptom, like the thing that actually drives patients to the clinic, is usually excessive daytime sleepiness.
Yeah, these daily, totally irrepressible, rapid lapses into REM sleep.
Yeah.
Sleep attacks, basically.
And for the exam criteria, those attacks need to have been happening for at least 3 months, right?
Correct. At least 3 months. But clinically, the average time from symptom onset to an actual diagnosis is staggering. It's about 15 years.
15 years. Oh, wow.
Yeah, I mean, it usually starts in their mid-teens. So for over a decade, they just get brushed off by providers as, another lazy or chronically sleep-deprived teenager.
That's so frustrating. And going back to cataplexy, the textbook trigger is intense emotion, right? Like laughter.
Laughter is a classic one they'll test you on, yeah. But it can also be excitement or sudden anger or deep grief. Any strong emotion can trigger this sudden, usually bilateral muscle weakness.
And it lasts for, what, a few seconds to maybe a couple of minutes?
Yep. But here's the absolute key for the boards. Consciousness is completely preserved.
Okay, so they're not fainting.
Exactly. It's not syncope. They're just losing muscle tone. That loss of tone is literally the physiological atonia of REM sleep just crashing into waking life.
It's like a broken light switch. It can't stay fully on for wakefulness or fully off for sleep.
That's a great analogy. And you see that same broken switch with sleep paralysis. When these patients are waking up or falling asleep, they find themselves awake and aware, but entirely unable to move.
Which has to be terrifying.
Oh, it is. They often describe a really terrifying sensation of suffocating, which makes perfect physiological sense when you think about it.
Because the intercostal muscles are paralyzed.
Exactly. During REM atonia, those intercostal muscles are offline. Even though the diaphragm is working perfectly to keep them breathing, the lack of chest wall movement makes them feel like they can't breathe.
Wow. And then you add hypnagogic hallucinations to that mix.
Right, those vivid, dreamlike, visual or auditory experiences right as they fall asleep.
So dreaming and paralysis are basically bleeding directly into their waking hours? But wait, if these patients are so intensely sleepy during the day, do naps actually help them?
That is a massive differentiator for the exam.
Because I'm thinking, with something like idiopathic hypersomnia, they wake up groggy, right?
Exactly. With idiopathic hypersomnia, patients suffer from severe sleep inertia. They wake up feeling heavy and awful. But with narcolepsy, patients typically find short naps to be highly refreshing.
Oh, really?
Yeah, a strategic 15-minute nap can drastically improve their alertness. That's a key clinical feature.
Good to know. But we also need to talk about pediatric patients because they don't always look like that classic sleepy adult.
No, they don't. This is a huge exam trap. The StatPearls articles emphasize that children might actually present with motor overactivity, inattention, or even severe aggression.
Wait, hyperactivity from a sleep disorder?
I know, it sounds backwards. But it's a paradoxical behavioral response. When young kids are profoundly sleepy, they fight it physically. They will literally bounce off the walls to stay awake.
So they end up getting misdiagnosed with ADHD.
All the time. And if they have cataplexy, those sudden drops in muscle tone can look like drop attacks, which leads to a misdiagnosis of atonic seizures.
So for the exam, if you get a child with poor school performance, drop attacks, and an ADHD or seizure label that just isn't responding to meds, you have to put narcolepsy high on your differential.
100%.
Okay, let's trace this back to the pathophysiology. Why is the switch broken? It's the loss of orexin, right?
Yes, loss of specific neurons in the lateral hypothalamus that produce orexin, which is also known as hippocratin.
So orexin is essentially the master stabilizer of the sleep-wake cycle.
Think of it like a seesaw. On one end, you have the wake-promoting reticular activating system, the RAS. On the other end, the sleep-promoting ventrolateral preoptic area, the VLPO.
Right, mutual inhibition.
Exactly. When you're awake, the RAS sends dopamine and norepinephrine to suppress the VLPO. When you sleep, the VLPO inhibits the RAS. Orexin is the heavy weight that sits on the wake side during the day, locking the seesaw in place.
So without orexin, the seesaw loses its anchor and just flips wildly back and forth.
Yep, rapid transitions between sleep and wake.
And what actually destroys those orexin neurons?
It's likely autoimmune. We've seen narcolepsy onset following strep infections or the wild H1N1 influenza. There was also a spike in Europe associated with the Pandemrix H1N1 vaccine.
Though for our Canadian students, the sources note that this vaccine spike was not observed in Canada, right?
Correct, despite using a vaccine with the same adjuvant. It's an interesting geographic difference.
Okay, so how does the MCCQE expect students to actually prove the diagnosis?
Well, step one is a trap itself. You have to rule out insufficient sleep.
Right, because a med student on 4 hours of sleep a night might have sleep attacks, but they just need a nap, not a narcolepsy diagnosis.
Exactly. You must use 2 weeks of actigraphy alongside sleep logs to prove they're getting at least 6 hours of sleep. If it's less than 6 hours, you halt the workup. You cannot diagnose narcolepsy.
Okay, so once we prove they're sleeping enough, then we do the overnight polysomnogram, the PSG.
Yes, but the PSG isn't to diagnose narcolepsy. It's to rule out sleep apnea.
Oh, because obesity rates are higher in narcolepsy patients?
Right. About 33% of them have co-occurring sleep apnea. So you clear that first. Then the very next day, they stay for the multiple sleep latency test, the MSLT.
This is where they take the scheduled naps.
Yeah, 4 to 5 20-minute nap opportunities spaced out every 2 hours. A positive test needs a mean sleep latency of less than 8 minutes across all those naps.
Meaning they fall asleep really fast.
Very fast. And they need a rapid onset of REM hitting REM within 15 minutes of falling asleep in at least 2 of those naps.
The SRAMPs, sleep onset REM periods?
Exactly.
Okay, let me throw a pushback at you. The sources mention the HLA haplotype DQB10602 is present in 95% of narcolepsy type 1 patients. So for the exam, shouldn't the student just order the HLA test to confirm it? It seems way faster than a 2-day sleep study.
Do not fall for that exam trap.
No.
No. While it's in 95% of type 1 patients, about 20% of the normal, completely healthy population also has that HLA haplotype.
Oh, so the false positive rate would be massive.
Astronomical. It has no common diagnostic utility. If you want a definitive biomarker test, you check the cerebral spinal fluid via lumbar puncture.
Looking for hypocretin.
Yes, a hypocretin 1 level of less than 110 picograms per milliliter in the CSF is strictly diagnostic for type 1.
Good to know. Let's move to management. Behavioral interventions first, so scheduled 15 to 20-minute naps, since they find them refreshing.
Yep, that's the foundation.
But pharmacologically, we target daytime sleepiness and cataplexy differently, right?
Entirely separately. For excessive daytime sleepiness, first-line agents are wake-promoting drugs like modafinil or armodafinil.
And second line.
Traditional CNS stimulants like amphetamines. Oh, and pitolisant, which is a histamine H3 receptor antagonist.
Right, because blocking the H3 autoreceptor increases histamine release, which wakes the brain up.
Exactly. But treating cataplexy is a totally different ballgame.
Yeah, the first line there is sodium oxybate, right?
Yeah.
Which is basically GHB.
Yep, a formulated version of gamma-hydroxybutyrate.
But wait, that's a potent central nervous system depressant. How does it make sense to give a heavy CNS depressant to a patient complaining of excessive sleepiness?
It sounds totally counterintuitive, I know.
Yeah.
But it works by fixing their fractured sleep architecture.
Because they wake up constantly at night.
Exactly. Sodium oxybate forces deep, consolidated, slow-wave sleep at night. By chemically anchoring that sleep-wake seesaw in the sleep position overnight, it drastically reduces the REM intrusion during the day.
And that eliminates the cataplexy.
Spot on.
But prescribing GHB has to be strictly controlled, right?
Oh, heavily restricted. It comes from a central pharmacy. And the onset of sleepiness is wildly fast, like 5 to 15 minutes.
Wow, that is fast.
So they must take it while physically in bed. not brushing their teeth, not walking down the hall, in bed.
And it wears off quickly, too.
Very. They literally have to set an alarm to wake up 2.5 to 4 hours later just to take their second dose for the rest of the night.
Wow. I imagine you really have to warn them about mixing it with other stuff.
Never, ever combine it with alcohol or other CNS depressants.
Speaking of patient education, driving safety has to be discussed at every visit, doesn't it?
Every single visit. It's a huge medical legal point.
And if we're worried about their driving, we use the Maintenance of Wakefulness Test, the MWT.
Right. Unlike the MSLT, which measures how fast they fall asleep, the MWT puts them in a quiet, boring room to see if they can forcefully stay awake.
Makes sense. Are there psychiatric complications we should watch out for?
Definitely. Mood disorders, especially depression and anxiety, are highly common. It's partly the neurobiology, but also just the severe social impact of the disorder.
All right, let's transition to the other side of the coin. Restless leg syndrome, or Willis-Ekbom disease. This is where patients are desperate for sleep, but a physical urge prevents it.
Yeah, it's a vastly different clinical picture.
It's an irresistible urge to move the legs, right?
Driven by abnormal, non-painful sensations. They describe it as crawling, creeping, or pulling.
But a key differentiator for the exam is where they feel it. It's localized to the deep structures, right? The muscles or bones.
Exactly, not the skin. If they complain of burning or sensitivity to their bed sheets touching them, that's likely peripheral neuropathy, not RLS.
Good distinction. For the MCCQE, students can lean on the URG diagnostic criteria, URGE.
The URG acronym is perfect here.
So U is the urge to move. R is it begins or worsens at rest. G is it's relieved by getting up and moving. And E, worse in the evening or night.
And when they finally do sleep, about 80% have periodic leg movements of sleep or PLMS.
Which is an involuntary dorsiflexion of the foot.
Yeah, every 20 to 40 seconds all night long. It just shreds whatever fragile sleep architecture they had left.
But when you examine them awake in the clinic, their neuroexam is totally normal.
Completely normal, which is crucial for ruling out things like Parkinson's or radiculopathy.
It's almost like an internal itch deep inside the leg that you just can't scratch. Pacing the floor stops it, but the second you lie down, the neurochemical misfire starts again.
That is exactly how patients describe it.
So what causes that misfire? I know there's idiopathic RLS, but the exam loves secondary causes.
Oh, they love secondary causes.
Yeah.
The big three are pregnancy, end-stage renal disease, and iron deficiency.
Okay, pregnancy, mostly third trimester.
Yeah, affects up to 29% of women, usually resolves post-delivery, but it does bump up their long-term risk of chronic RLS later.
And end-stage renal disease.
Affects up to 50% of ESRD patients. It's notoriously worse when they have to sit still for hemodialysis, but interestingly, it often completely resolves after a kidney transplant.
That's wild. But the third cause, iron deficiency, that's the real key to the pathophysiology, right?
It is the central piece of the puzzle.
Wait, if it feels like a nerve issue in the legs, wouldn't students assume it's a peripheral problem?
They might, but it's central. It's a dysfunction of the dopaminergic system, specifically driven by low iron stores in the brain, like in the substantia nigra in the thalamus.
Ah, because iron is a cofactor for dopamine synthesis.
Exactly. Iron is mandatory for tyrosine hydroxylase, the rate-limiting enzyme. So low iron creates a state of relative dopamine excess or receptor dysfunction centrally.
It's a brain issue projecting as a leg issue.
Precisely.
So checking a full iron panel, or at least a ferritin level, is absolute mandatory step one.
Absolutely mandatory. And if ferritin is less than 50 nanograms per milliliter, your very first treatment is iron replacement.
Ferrous sulfate, 325 milligram with vitamin C on an empty stomach.
Yep. But before you jump to prescription drugs, you have to review their medication list. There is a huge pharmacy trap here.
Oh, the drugs that worsen RLS?
Right. You have to avoid antidepressants like SSRIs and SNRIs, antipsychotics, and dopamine-blocking antiemetics like metoclopramide.
What about over-the-counter stuff?
Centrally acting antihistamines, things like diphenhydramine.
Which is huge because a patient who can't sleep might instinctively grab an OTC sleep aid.
Right. And not realize it's going to drastically amplify that creeping URG feeling in their legs. Mm-hmm. Caffeine is another one to eliminate.
Okay, so iron is fine, sleep hygiene is good. What's the first-line pharmacotherapy?
Alpha-2 delta calcium channel, ligands gabapentin or pregabalin, or dopamine agonists like pramipexole, ropinirole, or the rotogotine patch.
When do we prefer the gabapentinoids?
Usually as initial therapy, especially if they have comorbid insomnia, severe anxiety, or neuropathic pain.
Dopamine agonists make sense since it's a dopamine dysfunction, but don't they have some pretty wild side effects we need to warn them about?
Oh, extremely wild side effects. Pramipexole and ropinirole can trigger severe impulse control disorders.
Like what?
Sudden onset gambling addictions, hypersexuality, compulsive shopping, or extreme weight gain from binge eating.
Wow. You really have to screen for a history of impulse control issues first.
You absolutely do. But the second major trap for the exam, and this is critical, is augmentation.
Augmentation. This is where the medication paradoxically makes the RLS worse over time, right?
Exactly. With prolonged use of dopamine agonists, the symptoms increase in severity. The urge starts earlier in the day, spreads from the legs to the arms, and the drug's duration of action gets shorter.
So the drug gives initial relief, but eventually rewires the brain to make the baseline disease far worse.
Right. So if a patient on a dopamine agonist says their RLS is now hitting at 2 p.m. instead of 9 p.m. and their arms are twitching, what do?
Well, you definitely do not increase the dose.
Correct. Increasing the dose just accelerates the augmentation.
So you taper them off the dopamine agonist, transition to a gabapentinoid, and recheck their iron.
That's the exact management flow for the boards.
All right, let's quickly recap our core takeaways for the listener. For narcolepsy, you're looking for that irresistible REM intrusion. Rule out sleep deprivation with actigraphy, then confirm with MSLT or CSF hypocretin.
And watch out for the pediatric ADHD trap.
Definitely. For RLS, rely on the URG criteria. Check the ferritin level right away, rule out uremia and pregnancy, and beware of dopamine agonist augmentation.
Spot on.
You know, as you study these pathologies, consider how delicate the neurochemical balance of sleep truly is. In RLS, just manipulating dopamine to calm the legs can eventually trigger the brain to rewire itself, leading to augmentation or extreme behavioral changes like gambling.
It's wild to think about.
And in narcolepsy, the mere loss of a single neuropeptide, orexin, causes the entire wall between dreaming and waking to just collapse. How many other psychiatric or behavioral disorders might simply be subtle dysregulations in our sleep-wake architecture that we just haven't mapped out yet?
That's a profound thought to leave them with.
Thank you for joining us on this deep dive into sleep disorders. Keep up the great work in your exam prep.
Trust the process, and we'll see you on the next one.